to the fore, encourage dialogue and connect with people with their own humanity and that of others. People will forget what you did, but people will never forget how you made them feel. Not my words, but the words of poet Maya Angelou. These stories will be happy, sad, and I hope emotive and moving. Actions will have been taken to learn from and embed learning from them. But the important thing is that it opens up for discussion in what really matters to me, not what's the matter with me, so that we can improve things for our residents, patients, and staff by our collective action. So Mary was a much-loved mother, grandmother, and wife, 82 years of age, with well-controlled chronic kidney and heart issues. But despite this, she was an active volunteer at a local primary school, had been driving a car, playing chess, and running a house. This all changed suddenly within a matter of weeks. Her daughter described how Mary went from being her fabulous, independent, busy mum to spending all of her time in bed, confused, tearful, experiencing problems with vision, mobility, and needing help with self-care. Over a period of 7 months, Mary was assessed by 5 specialist services, which her daughter felt was disjointed and frustrating, with no one taking overall responsibility for finding out what was causing the rapid decline, so what mattered to Mary and her family, instead focusing on what they perceived to be their part in solving the problem, in focusing on what's the matter with me. Her daughter felt that this lack of coordination compounded continuity of care and led to a failure to diagnose in a timely and compassionate way, which missed opportunity to compassionately discuss, plan, and enable a good standard of end-of-life care. During this time, Mary had episodes of care within a hospital setting, which her daughter described as poor and lacking in compassion for both Mary and her family. This was care that was, as I've said, provided within the context of keeping people safe in a global pandemic. However, her daughter described communication with ward staff over the telephone as being difficult, with many situations of delayed access to information which were never fully resolved. A particular episode was described where, as an inpatient, Mary had become dehydrated because of inadequate fluid intake, which made her kidney problems and confusion worse. Mary was assisted to the toilet during this period and had an unwitnessed fall, which resulted in a broken hip and necessitated her staying in hospital for over a month, which added to the further distress for Mary and her family. Given the COVID restrictions at the time, visiting for the family was limited, which was distressing for Mary, her husband, and her daughters, who wished to spend as much time as possible with her. Also, while she was in hospital, a gold necklace was removed to enable a radiology procedure and was subsequently lost. Mary's daughter described how her end-of-life care was marred by a lack of communication between medical and nursing teams over the exact plan of care and how it was to be carried out, which led to delays in achieving discharge to an appropriate end-of-life care setting. She described personally navigating obstacles before her mum was finally moved to a hospice in the final days before she passed away. I would very much like to thank Mary's daughter for telling us this story and allowing us the opportunity to open up the conversation, which we did within a look back thing in improving things. So just by way of summarising what we did and what we will continue to do, as I've said, providing healthcare is complex. Whilst the healthcare landscape may evolve at times, with new research, emerging technology and innovative ideas, there are 6 standards that are a constant. They are compassion, care, communication, commitment, competence and courage. A system-wide review was undertaken. This took into account individualised individualised organisations' perspectives and reviews, including a serious incident review and root cause analysis of the inpatient fall. This was all collated and reviewed as a round table, with the overall findings of a lack of communication and a lack of coordination and continuity of care. And I draw you back to the 6 standards. All system partners recognised and participated in looking at this as a system, and great thanks to them for doing that. There were many recommendations and actions taken. I'm just going to summarise the kind of the broad spectrum. Within communication, this was from the very basics of ward level communication between nursing and medical staff, to documentation and conversations with families, to discharge summaries and shared care records implementation across the system. From a care perspective, this was ranged from the training of crew, patient transport crew, moving patients at end of life, to having clear and systematic assessment of frailty across the system, and quality of the advanced care planning and adherence to quality of advanced care planning. So making sure, hopefully, that we, through working as a system together, make sure that we focus on what matters to me, not what's the matter with me. Are we assured that this would not be the case today? We have a fair assurance that the system has worked together to make sure that the actions are enabled that will improve things for our patients. And I'd just like to again thank Mary and her family for bringing this opportunity to us to discuss this as a system. And I'll just pause there for discussion and any thoughts. Thank you.
Thank you, Kath. That was an incredibly powerful story that was shared with us, as you said, and I'd like to add my thanks to Mary's family for allowing us to share that story. I heard that story previously, actually, and I felt it was important because there were some clear system implications that actually we had the opportunity as a board to hear that kind of story again, because obviously what it tells us is where we have real opportunities for improving things, and that's what we're here for as an integrated care board. So I felt it was really important to share that with you, and I would encourage us, I think, to think about if there are, stories that patients tell us and give us permission to share. I would certainly encourage us to continue the practice of sharing patient stories, because I think it reminds us all, I know we know this is what we're here for, but we are here for addressing those things and improving those in a systematic way. And I particularly like the reference to the 6 C's, Kath, because I think those 6 C's stand, the compassion, the competence, the courage, etc. They stand very clearly as important things for us all to remember. Are there any comments or questions? I mean, I suspect Kath won't be able to answer anything in particular detail because it was slightly before your time, Kath, but just in case there's anything that we can even take away. Vicky.
Thank you, Kath, for that. It would just be really good to know as an ICB how we would keep track on the lessons learned from Mary's story. And I note that you say that it's quite a while ago, but just going forward, how we would track those improvements and update Mary's family as a continuing to make sure that we increase the confidence of our public.
Do you feel able to answer that?
Absolutely excellent question, Vicky, and something we've been reflecting on as to how do we make sure that we're making the improvements and we're keeping up the pace of making improvements. And I think that really we need to really make sure that we've got that within our governance system and everything. And I know you'll be ably taking over as chair of quality resources and delivery, and we have systems that sit underneath that to make sure, obviously, we monitor things and give feedback. And in this particular case, we've had a lot of engagement with the family and follow up with the family. But I completely agree with you, kind of in a systematic and a population-based way, looking at like the themes and things like that. There, we need to be taking that into our formal committees, and we need to be gaining assurance at this board that we are getting the traction that we need to.
Thank you for the question, Vicky. Any other comments or thoughts? Okay, so thank you very much again, Kath. Very powerfully reminds us some of those improvement opportunities we know exist, and the importance of us collectively addressing those together. I move on then to the strategic update section of our agenda. And just before we start that, I do want to just welcome colleagues who were unable to join us earlier, but therefore have arrived slightly late. Apologies that people have had some technical problems, but I think a number of people have been able to join us, so welcome to everybody. Okay, so without any further ado, we're going to move on to the Chief Executive's report, which is item number 8. Simon, I guess you'll just sort of highlight a couple of key things. There might be things, I'm conscious there are things in the report that are also picked up in a later, more detailed report, for example, agency spend, etc. So we might want to sort of pick up anything here in Simon's report that we're not going to have an opportunity to pick up later, and come to those other things later on. So over to you, Simon.
Yeah, thanks, Krishni, and hopefully everyone has had a chance to read the report. I mean, there is quite a lot in there, but it's designed to be a briefing type document for the board. I mean, we want to avoid having long agendas with lots of reports for information. And from experience, the best way of doing that is trying to put as much as we can into a kind of overview of the important strategic things that are happening in the system and in our organisation. So that's what the report intends to do. Just to pick out, Christian, if I can, a few things from the report. I won't go through all of it, but obviously on the first page, really significant that the COVID vaccination programme has restarted and is running us alongside flu vaccinations. It is important we take the opportunity just to remind people really how important it is. Immunity for all of us will have waned since our last booster jabs last year or earlier this year. The new round of booster jabs along with the flu jab will be really important. COVID and the flu virus will be circulating this winter. The winter's going to be difficult enough operationally. We need to give people as much protection as possible. So thank you to the teams who have been working on that, and a real message of encouragement to our public and to our communities to come forward when the opportunity presents and to have that vaccination. Just down the bottom of the second page, work has really intensified over the summer months around delegated commissioning. So a reminder for the board, we're working towards being responsible for commissioning pharmacy, optometry and dentistry from April next year, so April 23, and then a slightly longer term plan whereby we will also then take over some further specialised commissioning that NHS England currently does, but that will be April 2024. So we've got an 18-month period really of quite a bit of change in this area. You'll see in the report we've tried to draw out some of the concerns that we've got and some of the specific areas that we're working on, particularly in relation to financial due diligence, just making sure the delegation of responsibility and the budget match up, but also performance, particularly in dentistry. I suspect there's going to be a government announcement on the NHS this week. I'm sure dentistry access is going to feature, so we're going to inherit that responsibility in April. So it's really important that we fully understand the local position, particularly in Herefordshire. It really needs a lot of improvement. It's not great in Worcestershire either, but that will be one of the strategic challenges that we face as an organisation as we assume that responsibility, I am certain. Just moving over the page, so you'll see that we're about to start a pre-consultation engagement exercise on some work, long-standing work that's been going on around how we best deliver stroke services for our population. So I think this has probably been 10 to 15 years worth of work. We have just about barely viable services in both of our counties. We're trying to work on a system-wide model with actually support from other systems as well. Mary and various others have worked really hard on this over the years. We are in a position now where it appears we have a model that we would like to work up in further detail before we would proceed to any formal public consultation, which we would do because it would be a service change. The best mechanism is always to go through a period of pre-consultation engagement, and that's what's going to happen now, just checking with stakeholders and patients and community representatives that we haven't really missed anything significant, and that would be the purpose of this next phase of work. The report also picks up feedback from the forums that we have in our operating model. Some of those haven't met that often over the summer. When the forum meets and there's something significant, we'll probably feature that on the agenda. Otherwise, I'll just try and do an overview in this report. Then a couple of points to finish. One thing that's not in the report, which is important and is an omission on our part. So there is a point prevalence study taking place today across our system. So we're looking at every patient in every bed and in every care setting and just trying to work out the proportion of those that are in the right place, where there might be any delays, why there might be any delays, and trying to work out really what our efficiency and quality improvement opportunity is as a system as a whole. So that's quite an important event today. David Mahaffey has led that exercise, and obviously we'll be coming back to the board in the coming weeks with an overview of the early findings, and then we can have a further discussion. And last but not least, I'd welcome Vicky. So Vicky Morris has joined us as our latest non-executive member. He completes the board of the Integrated Care Board. So welcome to Vicky, who's been with us since the start of the month. So very happy, Christine, to take questions on any of those items or anything else in the report.
Thank you, Simon. Right, any comments or questions? David Mahaffey.
Yeah, it's not a question from me. It's that Nikki Berger's dialed in on the phone. She has a question but needs to be unmuted first and can't raise her hand. So if somebody could unmute her and allow her to ask a question, that would be great. Thank you.
Nikki, it has to be you unmuted because you're the organizer. I think Nikki's number is the 7900.
Nikki Allen, is that you? Can you unmute Nikki Berger, please? 7.
Let's carry on working on that, Christine. Maybe we'll move to David's question, shall we?
David Whiteman. David, you're on mute. Oh, actually, no, you're not on mute, but we can't hear you for some reason. I think we can hear you now.
Can you hear me now?
Yes.
Yes. Okay. You have to unmute twice, apparently. Simon, you mentioned about the strategic forums, and there's a strategic workforce plan coming through, which is absolutely great that that's being worked on. But a number of issues that came up. So the NHS 111 contract, we're talking about how long it will take to the time it will take to fill the potential workforce gaps. Can we start working ahead of time? Is there some pre-work we can do to understand what those gaps are going to be, rather than having to wait until the end before we start to fill them?
Yeah, Christian, very happy to come back on that. I mean, yes, of course, David. I mean, the strategic workforce plan is really important, but there are operational workforce challenges in particular services, and that's a really good example where, in order to effectively mobilise that 111 contract, immediate work needs to take place to fill those vacancies. So please be assured that the strategic side doesn't get in the way of the urgent day-to-day operational issues, and yeah, we'll be coming back, I'm sure, to seeking further assurance on that 111 contract transfer, because it's significant. There is risk, and we need to make sure partners in the system are managing that risk in the best way they can.
Thank you.
Thank you, David, for the question. I'm just conscious, have we had any luck in unmuting Nikki Berger?
Unfortunately not. Krishni doesn't let us unmute her at all. So I suggest any of the participants who can't join, if they wanted to email myself with any questions they may have, I can raise them on their behalf.
Okay, thank you. Vicky Morris?
I just wanted to raise a question about the delegated commissioning, Simon, that obviously there's clearly a transitional framework. I'm just wondering whether this board would have an opportunity to have a presentation from NHSE colleagues as part of that transition, if you like, a sort of legacy document, an opportunity to raise any questions, given the risks.
Yeah, I think that would be really sensible. I mean, we are developing a much better understanding ourselves of the risk, actually, and this will ultimately come to the board for a decision that do we accept this delegation. It is policy, so I don't think we have much choice not to accept the delegation, but equally we need eyes wide open and we need to understand absolutely what the due diligence is telling us about these services and what mitigations are in place, because as I say, some of this stuff is going to get really high profile, I think, and we understand, don't we see actually, particularly with things like access to dentistry, what an impact on the wider determinants of health that has. So it's both a risk but also an opportunity, but absolutely that the board will need to understand. So I'd expect later over the course of the remainder of this calendar year, I'd expect us to be having that detailed conversation as a board about all of that.
Thank you.
Thank you, Vicky, for the question. And I assume also, Simon, that this will be looked at through the Integrated Commissioning Committee as well. I would hope
yes,
that committee will look at this the proposals in more detail than we might be able to at board.
Yes, they absolutely will. So the Strategic Commissioning Committee that Sarah chairs, this will be a key agenda item, both managing the transition, but also it's that committee of the board that will take on the month by month oversight and management of that process as well. Krishni, Sarah has texted me and just said, are we going to work closely with NHS England given our concerns about access to NHS dentistry locally? And yes, absolutely we are. I think there are two elements to that. One, I think there is a national policy piece around how the national NHS dentistry contract is structured and the incentives and disincentives within that for dentists to take on that work. It clearly hasn't worked that well, I don't think, the national contract over the last 10 years, just based on what we see. So there's that element, and then there is the local element, and we know particularly in both of our counties, but particularly in Herefordshire, access to dentistry is really poor. It is going to feature, I think, in the safeguarding report that's going to be published later today. So we're going to have to take some local action in addition to the national initiatives around this, for sure.
Thanks, Simon. I mean, I think the key here is the due diligence, isn't it? Understanding what it is we're taking, what liabilities we're picking up, and I'm sure Mark would want to understand the financial implications of that, because we obviously the better the quality of our due diligence, the better, dare I say, we can negotiate with NHS England about what it is they're giving us and how they're funding it, etc. And particularly with dentistry, we know this is a real challenge, and access to dentistry is a key issue already for us, and therefore the support and the skills we will need actually to manage this contract, I think, will be significant. I can see that there are some other comments. Is there anything else on dentistry or specialised commissioning before, just in case we want to carry on with that? No. Okay. So, Hannah, did you want to come in on behalf of somebody?
On behalf of Nikki Berger. So this is under flu and COVID, Simon. So you mentioned that the Herefordshire and Worcestershire Health and Care Trust will take on the lead employer role for the vaccination programme. Can you please expand on this? And is this a change in provider going forward? If so, what consultation has taken place? And when is this change planned to come into force?
Yeah, I'm happy to expand on that. So where we were during the process last year. Most parts of the country actually did have an NHS trust who held the contract and the employment responsibilities. We were fortunate that Staywell, the Primary Care Federation in Worcestershire, took on that responsibility. The regulations changed this year, and for this vaccination campaign, that it had to be an NHS trust. So we've worked with Sarah and her team. In essence, they are just, it's a paper exercise that they are agreeing to hold that lead employer status, but there is a memorandum of understanding between the trust and the ICB, and we're basically going to deliver that on their behalf with support from Staywell. So it's an administrative change rather than an operational change, but one that was necessitated by national policy dictating that it had to be a local NHS trust. And look, I'm really grateful to Sarah and to Mark and their board for agreeing to take on that, because I think that's been quite a seamless transition, and certainly Nikki in the PCN, you shouldn't notice any difference at all really in terms of the operating model.
Thanks, Simon. David Whiteman.
Yes, thanks, Krish. Yeah. Yes, thanks, Krishni. Simon, on the quarterly system review meeting, you raised you mentioned 6 points which were discussed with the NHS EI. And some of those you clearly have plans in place. I just wanted to ask for assurance that on all of those 6 items which were discussed, that we do have plans in place to address those.
Yeah, thanks, David. I mean, those 6 areas are probably the 6 most important strategic issues for the system as of today. So absolutely, we do have plans. We'll cover some of them later in the agenda, but all of them, I'm sure, will feature on work programmes for either subcommittees or the board itself over the coming months. So yes, I can give you assurance we've got plans. I can't say that they will all be resolved immediately and the plan will work immediately, but we certainly are working hard with the plan we've got and to further develop and put further actions in place to try and mitigate those 6 significant strategic issues. And that's the point of the quarterly reviews we have with NHS England. It's to identify the most important and the most strategic system-wide issues, and then we talk about the plans we've got in place, the help and support we need from NHS England, which with some of those we do need their help and support, and we're working on that, and obviously then what we're doing locally with partners to try and mitigate some of those risks. But absolutely, we have plans for all of them.
Great, thank you.
Thank you very much. A couple of things just wanted to pick up myself, Simon, and maybe just wanted to check the ICS Reset and Recovery Forum, which is going to be looking at the sustainability of fragile services and things like that. Just wondered, this might be one for David or yourself, but just wondered where that fits into the operating model and where we're going to kind of see that reported through. So that was the first thing. And then the second thing, sort of similarly governance-y point really, or just in terms of action. The prevalence audit, I think this is really interesting piece of work, and actually, I think when we've shared it with other people, they've been really interested to hear about it and are very excited to see what outcomes we've had. And if I remember correctly, we may have done this sort of thing before some time ago. And the outcomes can be very informative in terms of a baseline, an opportunity for us to demonstrate progress. I just wondered what we would want to do in terms of reporting back on that. Do we think that's going to be at the next meeting? So it's really both about where's the ICS Reset and Recovery Forum reporting, and when do we think we will see, when and where do we think we'll see the prevalence audit results? So David or Simon?
I can answer both of those, Krishni. I mean, the Reset and Recovery Forum is part of the elective and cancer recovery stream. The outcomes of that predominantly will find their way to the Quality Delivery and Outcomes Subcommittee. So because it's a big performance issue, the forum is the means through which we're tackling a lot of the details. So that's where that report will land. Of course, we'll keep oversight here as well, because again, it's such an important strategic issue. The point prevalence audit, absolutely, we will include a report at our next public governing body meeting, public board meeting, because it's really important. But I would like us to carve out some time in the development programme where we can get underneath the detail. And similarly, just remembering it was the Finance Forum actually that instigated this work. So I know Mark, Russell and other colleagues in that forum will want to understand the detail and will want to discuss some of the opportunities and how that can play into forward-looking plans, really, I guess. So yes, there is a plan with both of those for them to feature in the things we talk about. Thank you, Simon. And that reminds me that actually, you know, one of the reasons why we did this is we wanted to understand how we need to how we might in the future shift our resources. And left shift is a term that is often oft used, but this was one of the things that we thought might enable us to do that, a really good understanding of where resources are used currently, so we can actually demonstrate in the future that we have shifted them appropriately. Thank you very much, Simon. Hannah.
Thank you. I've got a question from Sarah Raystrick about mental health targets. So there are a variety of targets picked out here in the report. What is our risk appetite or any decision to actively pursue? There are a variety of SMI health checks, proven benefit, dementia diagnosis being a long-standing issue. Are there plans to prioritise? How to change long-standing poor performance? How to move via mental health collaborative? Where do we get our steer as a board from the mental health collaborative?
I think it's a really good question. I mean, if we could unmute her, I'd bring Sarah in to provide a bit of flavour. But again, as the collaborative matures, I mean, obviously the mental health collaborative is working in a shadow form really this year, and all of the issues that Sarah mentions there, the long-standing performance issues, they're all part of the mental health collaborative agenda. So as we move towards next April and hopefully the collaborative becoming more of a formal delegation, clearly as a board we'll look to receive kind of performance and outcome data both into our subcommittees, so into the Quality Delivery and Outcomes Committee, but also here at board for those most strategic issues. And those things Sarah mentioned, again, are pretty important strategic issues. We've struggled for years in both counties with dementia diagnosis. The collaborative has come up with a number of new approaches to trying to improve that. So it's one of the key tests, isn't it? Doing it in a different way, is it going to get us a much better answer? So we're definitely going to want to watch that through the board. We'll have further conversations in our development programme again about that. But of course, the data will find its way here as well.
Thank you very much, Simon. And I'm sorry, Sarah Raystrick asked the question, as you say, if we could unmute Sarah Dugan, we'd probably have a sort of a further element that she'd want to add to that. One thing I will say, which I was very encouraged by, I did actually have the opportunity to attend a collaborative meeting, mental health collaborative meeting. As Simon explained, it's in shadow form. And one of the things that the meeting was looking at and was addressing, or the collaborative was looking at, is the challenge of meeting improving access to psychological therapies target, and workforce being a key issue, which we've touched on already as often a key enabler to some of our service improvement requirements. And I thought that the solution that the team had come up with was really innovative, in that there was a conversation about commissioning other wellbeing services outside of the mental health trust itself, and getting primary care to be involved in delivering those. Now, the challenge with that was actually, it's an innovative way of addressing that. It's supporting people's well-being and psychological needs using a different type of service, albeit one that perhaps doesn't meet the normal criteria. And Sarah would have explained this much better than I can. But I think the fact that we were looking for other solutions and commissioning other types of services that actually could fill a gap whilst we're trying to address the issues we've got is exactly the sort of solution we should be looking at if we're actually being innovative. So I felt it was a really good example of how the mental health collaborative can move us forward. I'm sure Sarah will be in a position to give us a better explanation of all of that at a future meeting, and in fact I'm sure we will include mental health as one of the deep dive topic areas going forward. I'm going to bring this particular section to a close. Thank you for all your questions and comments, and thanks, Simon, for the comprehensive responses. We do need to just cover 2 more items under our strategic update. So first of all, we have the ICB planning and priorities item, which is for approval, and then also following that, also with David Mahaffey, the integrated care partnership and the establishment of that. So David, can I hand over to you?
Yeah, thanks for that, Christiane. First, the 2 items, as you say, I'll try and be pretty quick and get through these so we can get on to discussion. The first one on priorities. This paper is seeking the board's agreement to the operational priorities that the ICB will need to focus on over the next 18 months or so. We've previously discussed the 4 strategic aims of being an ICS, which are, as a reminder, improving health outcomes, reducing health inequalities, improving value for money, and ensuring the NHS supports broader social and economic development. So we've used those 4 strategic aims in the development of these operational priorities. And if board members kind of cast their mind back to July when we met for the first time in the development session, we talked through these operational priorities, reflected on those 4 purposes, etc. So what this report does is takes the discussion that we had in July, subsequent feedback, and tries to present a kind of draft wording for the priorities for the board to agree. Now, I recognise there may need to be some wordsmithing around the exact way in which these priorities are described to make them easy to access and understand by staff and the public. But today we're just seeking broad agreement to sign off these principles in their broadest context, so we can then just do that final wordsmithing and embed these and get on to work with them. So I won't go through them in any more detail than that, but just like to open up at this point for further comments that we can take forward.
Jane.
Yeah, thank you. Unfortunately, I was on holiday when the draft came out that Hannah sent round, so I missed the cut in terms of some of those comments coming back. Most of it was around the wordsmithing, so I'll have a chat with David outside in terms of really the first couple. The one I did want to make a specific comment about was that third one there about embedding our agreed framework for clinical leadership, because I don't think we've got an agreed framework for clinical leadership to embed, and so the topic is right, but I think it's probably much more around how we engage clinical leaders at all levels to address our challenges and manage risk as a system. So I think that's probably what the aim really is. I think it's just got slightly ahead of itself because I don't think we've agreed a clinical leadership framework yet. So the other comments were more around, to say, the wordsmithing, but that was a bit more of substance in terms of that particular aim I wanted to make the point on.
Thank you, Jane. I think you're probably right. I'll bring Will in to comment. I think there was also some guidance last year, wasn't there, about clinical and care professional leadership model. I think it was some guidance that was issued last year about how we and something that we need to use as the basis for taking this forward. But I think it was very much, Jane, about developing that framework and agreeing it and making sure it works for us. But I'll ask Will to comment. Thank you.
So in terms of the framework, there was a framework written for the inception of the ICB. It was one of the requirements of the go live, and that was done admirably by Carl Ellison. So that sets out some very broad principles, the way we want to engage with clinical and professional leaders across the field, and actually clinical professionals on the ground who are actually involved in developing new pathways and working alongside patients. I think what we are doing now, Jane, is more about actually the practicality and the structure of embedding those very broad principles, and a lot of that is evolving over time, and yeah, more than happy to bring back a few more of the specifics to this group if we want to in the future, as we put it on the ground and see what works and what doesn't work.
Thank you very much. So it's so clearly there is a document, isn't there, Will, from what you're saying, and that was a requirement of the ICB establishment. But we've clearly got to bring it to life, Jane. So it may be that embedding is perhaps not the right word in that context. It might be there's something about engaging people with the actual document in the first place, isn't there? Clearly. Is that okay, Jane?
Yeah, I think my point is probably it's not about engaging with the document, it's about engaging clinical leaders in how we manage risk and how we address the challenges. So I just think our aim needs to be structured around what we're actually going to do rather than focusing on a document it feels like it's doing.
Yeah, no, that's very helpful, Jane. I'm sure Will can have a look at that. And we'll perhaps, David, if there are no other comments, anyone else want to make any comments? I think this has been sort of socialised, if I can use that word, quite a bit already, hasn't it? So hopefully we've picked up most things. Hannah, did you want to bring someone in?
Yes, I've got a question that just come in from Sarah Dugan. So Sarah says, I would like to ask about the joint forward plan and the rationale that this only relates to trusts only. I'm keen to ensure we also have a multi-agency place-based response to the areas agreed in the strategy. Does this plan replace the current planning requirements for the NHS? And if so, am I right in concluding we will oversee the multi-agency elements through health and wellbeing boards and place leadership groups?
Thank you, Hannah. Who would like to answer that? David?
Well, I can start, Christian. The specific guidance about exactly what the joint forward plan is going to be have not yet been published. So we're a little bit in the dark beyond knowing what the intention of the joint forward plan is. But they are expected in October, and the intention is that the ICB takes ownership of the production of this document, which essentially brings together all of the key operational plans of the trusts in our system. So it is specifically NHS planning aspects of the guidance that we will need to see. Clearly, there's a much broader piece of work to be done around the integrated care strategy, which is the document that the joint forward plan must have due regard to, which will be published in December, which will pick up much more on the multi-agency, wider determinants of health, etc. So those two things kind of need to sit hand in hand. We know a lot more about the integrated care strategy. We don't yet know the detail about what the joint forward plan will need to do, but as soon as that becomes clearer, we will obviously bring it to the board.
Thank you, David. So that there's a sort of the integrated care, the joint forward plan is the NHS response, in simple terms, to the integrated care strategy. I think that's right, isn't it?
I think that's absolutely the clearest way of looking at it in this context.
Okay, great. Hannah, was there anything else?
Yes, there's also a question from Sarah Raystrick. So she's asking, are we in a mature position with open relationships to meaningfully overlay existing organisational strategies and overlay and build on these to help with the system framework and to pose questions to organisations if strategies do not fully align? If this is an additive that will lead to outcomes greater than the sum of our parts.
That might be a hard one to answer. I'm looking at Simon. I think that's probably a question for our board development session, I would suggest, rather than for us to debate here. But I do think we do need to debate that. And this is part of the learning that we're going to need to go through. The honest answer is probably no. If I'm being quite straightforward, I'm happy to be challenged on that. But I think that is what setting up the ICB is about, actually, is we're all here together on this board and we have an opportunity to work together to change how it feels and make sure everything is aligned going forward. So I think that's the challenge in front of us. So just that's a word from me, but Simon may want to comment too. Simon.
I was going to say something similar to what you said, Krishna. I don't think we are yet in that mature place. I think we still have kind of individual organisational strategies. We still try and knit those together into a system strategy. We have a lot of maturing to do in the strategic planning, forward-looking area, without a doubt. So, I think it's something that we really need to focus on to make sure that we get that alignment. I was at the Worcestershire Exec Committee meeting last week, and Joe Newton came and gave a very coherent presentation of the Worcestershire Acute Trust refresh of their strategy, which is really good, but actually we'll know we've arrived at the right destination when we haven't really got individual organisational strategies. We have place-based and system and even pathway-based strategies. So we have a lot of work to do here, and that's the role that David and his team need to play, is to try and knit all that together and to take us on that journey so that there is consistency and coherence and real focus on the right things at the system and at place level.
Thanks, Simon. Just a final comment really is, I think, to be fair, I think, many systems are in a similar place, and certainly in some of the planning submissions that we've made, I think consistent feedback is, what the region tends to see, or particularly region, because they tend to receive them first, is sort of a submission that looks like it's just 3 documents put together, rather than something that really feels integrated and cohesive. And that's been the case now for a year or two. That's the feedback we've routinely had from region, that it's how we really make it feel like something that's joined up from the start, rather than something that happens to be just 3 things pasted together that with a nice template around it that looks like it's integrated. So work to do, but that's the journey we're going on, I think, is probably the message. So if there are no other comments, David, I think, can I just check with everybody that we're formally happy to approve the proposed priorities, recognising the comments that Jane has made about making sure we present the clinical engagement bit of that appropriately. And there might be some sort of fine-tuning to do on the wording, but fundamentally and kind of on the broad thrust of the priorities, everyone happy to support that, subject to some fine-tuning. Is that okay? Great. Thank you very much. Thanks to David and others who've been involved in pulling that together, and we'll leave it with you to finalise that, David. So back to you on the establishment of the ICP then, please.
Yes, thanks. And this is a good juncture actually back to Sarah's question about how this all fits together, because the integrated care strategy, which is the only statutory requirement of the integrated care partnership, is to oversee the production of the integrated care strategy for the system, is intended to be the umbrella strategy that pulls everything together that we collectively do as a system. So it's not intended to be a kind of a 300-page document that defines everything in detail, but is intended to be a framework that we can all work towards as partners and people in this system. So that hopefully will start to provide us as a system with the framework that we need to go through the process of joining up what we do better than we do at the moment. So this paper, the second paper, is about just getting endorsement to that integrated care partnership approach. So just to remind everybody, the integrated care partnership is a new statutory joint committee between the integrated care board and the 2 local authorities that are responsible for social care and public health functions. So that's Herefordshire Council and Worcestershire County Council. And the partnership needs to oversee the production of a strategy, an integrated care strategy, that needs to be published by December of this year. So all partners then have to have due regard to that strategy when developing their own implementation plans. And as we previously discussed, for the ICB, that implementation plan will start with the joint forward plan and then the work streams that feed into the joint forward plan. So say the first iteration of this strategy needs to be published by the end of December, but it is recognised nationally that the timeline between forming integrated care systems formally in July and publishing its first strategy in December is quite short, particularly because there's an expectation of significant engagement with the public around forming the priorities to underpin that strategy. So the recognition nationally is that we should take time, particularly in the first year, to do that engagement properly. So we won't set out to for the integrated care partnership to publish that strategy on the 1st of December that then gets set in stone for the next 5 years, but sets out a framework for how we will get a good strategy over that period of time. So just going back to the purpose, the Integrated Care Partnership is the group that will oversee the production of that strategy, and the purpose of this paper is just to get the board to endorse the terms of reference, the membership model, and basically sign off its commitment as an integrated care board to that partnership. The board's also asked to note the requirements of the integrated care strategy and the contribution that the ICB will need to make, which is briefly outlined in the report. And I'd just like to emphasise that we'll spend time at the development session in October to go through the detail of this in more, in more granularity, so we can really get under the skin of what we need to feed into the strategy and the partnership over the next few months. So that was it, Krishni, for me on this paper.
Thank you, David. So I think it's just for noting that the process that we're going through in the establishment of the ICP and then the integrated care strategy. But if there are any questions, we do have a few minutes for that if anyone would like to raise anything. David Whiteman.
Yep, mine is a very small point just on the terms of reference. So point 4.3, attendance on the terms of reference, 4.3a. I just think we need to sort out the wording there. It doesn't make it clear about people being available by exception. I think if we shuffle the words around a bit, David, we can make that make sense.
Sure, I will make a note of that and take that forward.
Lovely, thank you.
Okay, so if there's no other comments, we're just asked to note that the requirements really for the ICB and the timeline, and obviously this will be coming back to us, David. So just to be clear, it's coming back to us in our next meeting for an update, or just remind me.
So for the October development session, we'll be talking a little bit more around the strategy framework, and this will obviously emerge further from then. We'll then need to talk about it again in the November board meeting, because we will need to be in a position where we're broadly supporting the direction of travel around the strategy for publication in December. I suspect that we would then possibly have a little bit of time in the December development meeting just to finalise things before we actually publish.
Okay. Thank you very much, David. Okay, we are shortly going to be moving on then to the system performance and risk section. I'm just debating whether we can maybe take a 5-minute break. Would that be acceptable, Hannah? I don't know how that works in terms of live streaming, but would that be okay? And then we can start again at 10:50.
I am not sure. Let me just find out really briefly. Krishni Tom has just left the office, so just one moment. Yep, that's absolutely fine.
I would suggest we just turn our cameras off momentarily anyway, and microphones off. But if we can reconvene at 10:50, I think that would be good. Thank you. Hannah, can I check whether we are still live? Whether we need to wait for it to start?
Let me just check with Nikki. Just one moment, Krishni. Sorry. We are good to go, Krishni.
Thank you, Hannah. Right, welcome back, everybody. So we start on the system performance and risks section of our agenda. So first of all, item 11 is an integrated report, really looking at quality finance and outcomes. Obviously, there are a number of different leads on this. So, Mary, I don't know how you want to play it. Your initials are first on the list. So is there anything, it's obviously quite a comprehensive report, Mary. So let us know whether, is there anything you want to update on in terms of what's in the report, or just particularly draw our attention to? Bear in mind, everybody, that we're going to be talking about ambulance handovers in particular in the deep dive, so we may want to sort of save anything around that for that. But otherwise, I'm happy if you want to just go straight to questions, because I suspect there might be quite a few. So how do you want to play it, Mary?
Okay, thank you. So myself and Mark, we're going to provide the overview of this report. I mean, I'm happy to go to questions. Just, I think the thing we need to note at the moment, separate to ambulance handover delays, is the concern around cancer performance at the moment. Yeah, there is a significant deterioration in our position. Out of the 9 cancer standards, 7 of them we are not achieving, and we are seeing a growth in referrals. We are seeing significant workforce challenges. We are, for Worcestershire, in tier 1 escalation for that being one of the reasons. Elective care is the other one. So, you know, we are taking the same approach we have taken to 104-week waits for elective, which has been successful. We're taking the same approach to cancer. Slightly more challenging because cancer pathways are definitely more complex than the elective pathways. And we are meeting weekly with the region as part of the escalation to go through the actions we are taking on the best practice cancer pathways to ensure we're implementing at pace and reducing the risk to patients that is obviously evident if they're not getting onto a cancer pathway quickly enough. So there's a lot of detail there. I'm happy to take any questions on the.
Thank you, Mary. Colleagues, any questions on the report that is presented in front of you? David Whiteman.
Yes, thank you, Krishni. The question is about workforce. So there are clearly some really good and necessary actions being put in place, but I don't see from the report, and it's a question really now, do we have a full understanding of the reasons behind increased turnover and vacancy rates, or do we have data which we understand and can rely on to understand why these rates are going up?
Okay, thank you. I mean, Katie's obviously our new people director. From the feedback I have, that's still a work in progress, David. That's still analysing all the data. It's becoming clearer. You know, particularly like the concern is the clinical workforce. You can see from the report there's the turnover rate and the use of agency in the clinical workforce is the concern. You know, I think it's nationally discussed, isn't it, that about clinicians leaving the workforce and the reasons why that is happening. I think Katie's just doing that deep dive in our own ICS to ensure there's nothing else that's being missed. Okay. So, you know, it's something we could do a further deep dive on top of this report through either the quality committee or back to here to give further assurance.
Thank you.
Thank you. Thanks, David. Jane?
Yes, I mean, I think, you know, it is part. Sorry, you know, as a reflection from a provider, you know, it is a national problem. We're all facing the same problem, but it would be really helpful to understand the sort of benchmarking between different organisations and sectors, particularly against social care as well as primary care sectors as well, in terms of that turnover. Mine was just a point of clarification, really. It was just in terms of cancer, because the Herefordshire position is quite different, actually. I mean, it's above the national benchmark. I mean, it's not great as a national benchmark, but we're at 67% for the year to date. So, so lots of things to work on in Herefordshire, but I think you've drawn that out in other areas, Mary, and so I just wanted to make that point.
Thank you very much, Jane. So this is another key priority for the system, which is clearly why Mary highlighted it. And just in terms of our understanding, I think, around this, if I remember correctly, Mary, there was reference to harm reviews. I think I'm referring to the correct section. I think there was reference to harm reviews. And I really just wanted to, I suppose, I don't know whether it might be helpful for us to understand a little bit more about whether those harm reviews are highlighting, I don't know, particular, so if I can connect it to inequalities, is there anything that we're actually doing to understand whether there is sort of additional harm, if you like, for more vulnerable members of our society? So the inequalities angle of this, I just wondered whether there's any clarity and whether things like harm reviews help us to understand that, or am I being too, is that too much of a sort of connection that I'm trying to make?
I think it's something we should be striving towards, Krishni. I think, you know, we are looking at the waiting lists and backlogs from a health inequalities perspective across the patch. What we haven't done as yet is link that to the harms. I mean, the harms for people waiting cancer referrals aren't immediately seen, and the elective aren't immediately seen either. So I think it's something we need to mature and develop towards, but we're not quite there yet.
Okay. And clearly from your articulation of the fact that there's sort of level tier 1 scrutiny, I think, on our cancer performance, this is a significant area of focus for us nationally and regionally. And we're obviously actively focusing on that, particularly in relation to Worcestershire. I think that's important, as you said, to note, Mary. Are there any other questions in other areas? I know David has mentioned workforce. Is there any other areas that people would like to explore on this? Vicky?
Just a question really on the finance section, because in terms of the identified actions for the improving trajectories, has there been any inclusion within the finance of those revised costs of being able to do that? So revised action plans and the costs of those into this system financial plan?
Mark?
I'm quite happy to come back on that. So thank you. It's a good question and one we're looking at the moment. So the plan as we've got at the moment is the plan that was signed off and set at the beginning, it was the end of June actually, which is there at the moment, which we're working towards. The new actions we're continuing to look at the moment around workforce, around some of the areas around performance we need to address, we need to get those built in. We do have specific funding for cancer, for example, that we need to work out and make sure that that's maximised, and some of the workforce modelling, once that's complete and we start to see the impact and benefit of some of that, will also impact on our level of spend we're seeing at the moment around agency, for example, which is very high, and we're over our agency cap at the moment. So again, these all integrate and we will build them in as they become developed to look at the opportunity, but also where we need to target additional resource in those areas.
Thank you.
Thanks, Mark. David, I have a question on agency. So was yours on agency as well? I just thought, as Mark has just mentioned, that I can follow up unless yours was also linked to that.
No, mine was on something else.
Okay, I'll bring you in shortly if that's all right. Mark, so just on the agency spend, I mean, I think one of the things that it's really important for us to recognise is agency expenditure is often a quality issue as well as a financial issue, because excessive use of agency staff, it often is lack of consistency in staffing arrangements and things like that can kind of lead to quality issues as well. So it's clearly in our interest to address that, and I know it's a major issue for everybody. I suppose my thoughts are we likely to be able to recover that position given the overspend that's already in existing, and the threshold that has been set by the national team, I think. So I know we've got an agency task and finish group, but it seemed to me, what are the areas of focus around that? Because, can we exert common controls? Are there particular areas where we're using agency staff where, we need to have a concerted focus on a permanent workforce solution? So just perhaps a bit more on that would be helpful.
Absolutely, I'm happy to come in and start that one, Chair, and if colleagues want to add to that. So absolutely, you're right, we do have a system agency cap now that was calculated by the national team, which is set for this system at £49 million worth of spend for the year. The plan that we submitted back in June showed we were looking at an agency spend of around 47.9 at that point. However, because of the workforce challenges that we've talked about and are evident, and some of the other operational challenges we're seeing, our level of spend is still higher at the moment. And you're right, not only does that drive a financial pressure, there's the continuity of care issues and the constant changing around staffing in the areas. We break it down and we look at it from a medical perspective, but also a nursing perspective, to see where some of the drivers are behind that, because as we know, as resource and workforce challenges increase, the supply and demand issues around agency increase, and therefore the price that you have to pay goes up as well. We're also impacted particularly within the Herefordshire side around the rurality side, which again forces some of the prices up in that area. So there are a number of actions we're looking at linked to recruitment, linked to retention, as to how we look to reduce this. Can we recover it? If we can turn and implement some of those actions quickly, yes. We can certainly see a slowdown of that expenditure, because as we know, part of what we pay is the premium to the agency. So it's not just the cost for the staff, but it's the premium aspect. But it's going to be very challenging, particularly as we go and we head towards the winter now, as to how we turn that round. But we will keep looking at those actions and what the opportunities are in terms of not only the quality benefit, the workforce benefit, but also the financial benefit of that as well.
Thank you, Mark. David Whiteman.
Thank you, Krishni. Another one for you, Mark, actually, and it's on the early spend on capital spending. In my experience, capital spending is normally delayed rather than early. So it's just a comment to say that actually we need to watch that really carefully, whether that is actually going to be an overspend, because an early spend is so unusual on capital projects. Just a comment.
Thanks, David. David Mahaffey.
Hello, we're sitting together, so it's very strict. Thanks, Krishni. It's probably another question for Mark, really, and that kind of complicated area of continuing healthcare. And I see that you note that there are plans underway, and the tone of the report looks as if there are concerns, but as if there's a degree of confidence. And so really, I'm asking the question, with that potential sort of significant variance against the budget, what are your levels of confidence that we understand the problem and that we've got plans that will really mitigate such a significant and quite volatile situation.
Okay, I'm happy to pick this up, or part of this up now, Christy. We will cover it a bit later on the agenda in the ICB specific section. I suppose I'm flagging at the moment from a system perspective against the system plan that we are off plan year to date. It's the ICB part that's driving that plan, which I'll talk about when we get into the ICB finance report, and it is continuing healthcare that's driving that level of spend at the moment from a volatility perspective, predominantly around price. We're seeing a big price movement linked to inflation, but I'll cover that a bit more in the ICB financial update, and I do have some genuine concerns around that level and that area at the moment, so I'll come back to those if you're comfortable with that, Chair.
Yeah, thank you very much, Mark. I think that would be helpful to pick up under item 14, so we'll explore that again. Okay, a couple of remaining questions. One from Aman. Aman?
Yeah, thanks, Krishni. It was just a question around the efficiency savings. I mean, how are we going about doing that? Because are we taking a system-wide approach to that? I just wanted to understand a bit more of what work is being undertaken to look at efficiency savings across the system, because they might help in terms of operational efficiencies, and sometimes that can lead to helping out with capacity when it comes to workforce as well. So it's just really to understand what's happening across the board around that, if that's okay.
Thank you, Aman.
Absolutely, I'm quite happy to come in and start on that one. Chair and Mary might want to pick up from some of the operational side as well. Absolutely, NHS efficiency savings always in the past have been, you could look at it in different ways. I've heard the word salami slicing, applied efficiency, lots of different ways effectively that's trying to restrict levels of expenditure and take cost out. I think where the NHS is at the moment, and we're no different as a system, the opportunity to take cost out is becoming more challenged and difficult. So we do need to look at different ways of doing it. So we have a best use of resource programme across the system that's focusing on a number of areas. So we look at benchmarking around model hospital, getting it right first time. We look at agency expenditure benchmarking, digital, for example. So there's a lot of number of areas we're looking at that will allow us either to look at how we take cost out or create headroom around productivity so that we potentially could absorb more work, look at repatriation and how we make best use of the Herefordshire and Worcestershire pound differently. That does need a bit more traction behind it, and that's an area. So at the next finance forum later this week, we'll be doing a deep dive into each of the areas and the programmes. We need to get behind what's the size of the opportunity a little bit more, because you're right, at the moment across the system we're behind the plans in terms of where we need to be. Now some of the things offsetting them are non-recurrent. That puts pressure on the underlying position going into next year. So we probably do need to look from a system perspective at how we refocus, re-energise around best use of resources, transformation, productivity, and how we can start to see some of that traction and impact. So there'll be a lot more of that built into the plans going forward, from an operational perspective, but also from a strategic perspective as well.
Thank you very much, Mark. Final question from Jane.
Yeah, thanks. I just wanted to bring out, it's around workforce, but it was bringing out sort of a bit of a broader point really around how we take care as the ICB on what we try to do at ICS level and what we do at place level, because we certainly talked in terms of when we set all of this up that everything would default to place, and so there are some examples here in the workforce section which seem to be about doing things at ICS level. I guess a couple of examples I'll bring out is there's a recruitment fair event for the end of the year. Well, if that's held in Hereford, it's not going to help Worcestershire. If it's held in Worcester, it probably doesn't help Kidderminster or Redditch or Herefordshire. So, a single recruitment fair event, that doesn't feel like that's something that we ought to be doing at that system level, because we are so diverse and we're such a huge geography. guess another example would be, the introduction of a financial wellbeing hub. I'm not quite sure what that is, but I do know what we're doing in Herefordshire and the way that we're trying to support staff, and we're pointing them at resources that the council have to support. So again, it's just being clear that we're not duplicating things at system level, because we're all trying to do the right thing and make it better. But actually we end up duplicating and we're diluting the things that we're doing at place. And on the other side, as an example, in fact, it says occupational therapy service. I think it means occupational health. Now, occupational health is absolutely something we want to deliver right across the ICB, because it's too small as a service split up in the way as it is now. So I just think we need to take care that we're doing things at the right place. And there were just some examples there in workforce where it felt that we might be heading in some directions where we're not necessarily staying true to the principles we set out at the beginning.
Thank you, Jane. Simon, do you want to comment?
I was only going to come back on that if I can, Christian. I mean, Jane, I think they're really good points, and we need to keep challenging ourselves, don't we, that we get this right. Of course, with some of the examples, there's a system element and there's a place element, but the two have got to complement each other and not contradict each other. But you're absolutely right about those examples you gave. Financial well-being, really, we need to get alongside the councils, don't we, and the communities to do that right, and that's where we can add the most value. So keep challenging us, Jane, on that. I think that's exactly the right thing to do, and we'll get it right, won't we, over the months ahead. I'm sure we'll get the balance right.
Yeah, Jane, I would support that as well. Just to say that I think we just need to be really clear. I mean, I'm sure Katie in her work, I know, is engaging very much with the relevant HR directors. So I'm sure that there isn't a situation where we're cutting across things that others are doing. But you're absolutely right. It needs to add, whatever we do needs to add value when we work at system level, and it's really important that we maintain that focus. We certainly haven't got the luxury of duplicating effort, not least because financially that does not make sense either. So absolutely need to keep focused on that. Thank you very much, everyone, for comments and questions. I think we've noted some really, there is no doubt we're in a very challenging place. And we need to, work together to address some of these issues, and also make sure colleagues are working, supporting colleagues who need support within their own areas of focus. So I can see that another comment has come in. It'll have to be brief, Hannah, because I'd like to move on because got still a lot on the agenda.
Really sorry, Krishni, thank you. A question from Nigel Fraser has just come in. What is the proposed intervention that will stop the move to more agency as workloads increase over the winter period? Increase in work pressures are likely to push more to consider moving away from substantive employment.
Mark, do you want to just make a final comment on that? I guess we're probably sort of similar to the conversation we had a little bit earlier, that you'll need to focus on that through the finance forum.
I think we'll look at it through the finance forum, but I also think it'll be picked up, Chair, across HRDs and workforce and the workforce planning. I think it's a risk that we all know very well, and one that we have to manage carefully. There is no easy answer to that, but again, we need to look at recruitment, retention, lots of different ways that have been talked about already in terms of how we address this, and I think it's an area we'll probably continue to talk about, Chair, as we go forward.
Thanks, Mark. Unfortunately, I really think this is one of those things where there is no silver bullet or magic bullet answer to these things. I mean, interestingly, I will just reflect briefly that I chaired the Regional People Board yesterday, and Katie, obviously, as our Chief People Officer, was participating alongside with Chief People Officers across the whole of the region. And there was a deep dive on retention, and actually, just because obviously I think one of the things we need to recognise is actually retention is a lot cheaper than recruitment, keeping people, but that's a multi-layered issue in itself, and there are so many different staff groups affected by different factors that actually trying to deal with that in a sort of at a higher level is not helpful. But one of the things the region agreed to do was to actually bring all the Chief People Officers together to focus very much on the sort of high impact actions around retention. And I think it might have been mentioned in the report that it also includes funding for a retention lead in every system. So these are quite important things, because I think there's a recognition that needs to be our focus, trying to hold on to the good people that we do have and support them appropriately, because well-being and burnout is a significant issue within the workforce as well. So it's an ongoing challenge. Personally, I sort of feel workforce is our biggest risk in many ways, because at the end of the day, everything we do really needs people, and enough of them doing the right things. So no doubt we will need to do more on this. And again, it might be something we'd want to focus specifically on as a future deep dive once Katie's had the opportunity to do a bit more analysis on some of the issues underlying attrition rates, that sort of thing. So thank you for everybody's questions and comments. We'll move on then to our deep dive, which we built in really just to enable us to really focus on a key area, and ambulance handover delays is one such significant risk that we've been experiencing now for a little while. So Mary, do you want to introduce that for us?
Thank you, Krishni. Thank you. So yeah, I mean, nationally, ambulance handover delays are a priority. It's something that we've seen an increase across the whole country in the last, I'd say, 18 months, 2 years. Particularly ambulance delays over an hour, which is, standard we should not be achieving at all. It should be a 15-minute handover. So what we provided for you in this report is our current position at the end of August across the ICS. So it really outlines that we've, post the pandemic, we've now started to see a stabilisation in both ambulances coming to hospitals and ED activity, A&E activity broadly. We did have a spike definitely post-COVID. It has stabilised across the ICS. But our delays, particularly in the Worcestershire system up until the end of August, have been significant, and on one of 10 trusts nationally that are of national scrutiny from the Urgent Care League nationally, which we have weekly to go through our improvement plan. And this is causing concern from a risk point of view, that patients waiting for ambulances in the community, particularly category 2 patients that should have an ambulance to them in 18 minutes, are getting those ambulances. Our performance has deteriorated, and the risk and harm to those patients is obviously significant. We are doing well in some areas. So our WMAS colleagues, they're hear and treat, which is the phone calls they make to patients and resolve the problem over the phone. Those levels have improved as well, and also our length of stay in our hospitals. We benchmark well across the region for 7-day, 14-day and 21-day length of stay, which is a national measure. And for criteria to reside, those patients waiting in hospital that no longer need to be there, we do benchmark very positively in that position as well. But significant risk, significant concern and escalation all the time. We provided you with some data to back that up. So taking the two places separately. So Herefordshire, whilst they've got much fewer numbers of over ambulance delays, they really are maximising the opportunities of the developments they put in the last year. And I just want to pick out one really. I'm sure Jane will want to come in at some point, but one that we can see is making a difference from an ICB. Putting in that pit stop, that ambulance sort of handover area, with the ability to make very early decision making with them jointly between their ED and their medical staff. That went fully operational in November last year, and we can see daily the impact of that within the Herefordshire system. They do have difficult days still. I'm sure Jane agrees, it's a small hospital. The number of ambulances they get some days does quite shock me, to be honest. But they do manage that front door provision well. And they are doing same-day emergency care. They're growing their ability to do same-day emergency in a positive way as well. There are some areas of focused improvement still going on. So best practice ward rounds to make sure discharge planning is done effectively and timely is work ongoing. Improving the frailty pathway. If you analysed our 2 trusts and the amount of frailty patients going through our 2 trusts with our age demographic, it's quite significant. They're improving that pathway, and direct admissions to other assessment areas out of ED is another focus for them. and implementing virtual wards, managing patients in their own home virtually with support from the system, integrated system, to avoid admission is something that's going to be implemented over the winter to make a start on that different way of working. And then managing out of area delays, a significant issue for Herefordshire. You know, they're an importer from many of the counties around them for patients who it's often difficult to get back into their own counties, and managing that relationship is challenging. For Worcestershire, there is obviously the Home First Committee that manages the urgent care improvements. And what we've done as a place-based system has done is taken the urgent actions out of that large plan and integrated it with a winter plan in Worcestershire, and that is attached in this paper, and that is what we're reporting weekly on now to the regional and national team to give them greater assurance. We are putting in a much more rigorous assurance process ourselves. So behind each of these actions, we are now identifying weekly tasks for the next up to 8 weeks. And we will be putting a much more stronger, robust governance assurance process in place to make sure those actions have actually happened, and we can then see the intended outcomes. And that is part of us being one of those 10 nationally challenged teams at trusts, and we need to have greater assurance. Acknowledging we're asking all of the partners in the system to take further risk in the urgent care pathway, particularly across Worcestershire. We are undertaking a system-wide risk assessment. It's currently in development, and that will need to be agreed at ICB level. There is obviously a lot of concern from clinicians, managers, operational staff, which we all fully understand that the risk level is now becoming of concern because we're pushing more patients at greater speed through our systems, and we're going to support them with a risk assessment to ensure that governance is in place. But pleasingly to say, there's 2 big actions that are being progressed at pace in Worcestershire. Now, the first one is the North Bristol push model. You've heard me talk about pull models at VD before. We've now implemented that. We're in the 3rd to 4th week of implementing that in Worcestershire, and we have seen some significant improvements up until, or particularly over this long weekend. Probably the best we've seen our position in ambulance delays for, I'd suggest, 18 months really. It's in its early days, so there's still growth, there's still opportunity to improve, there's still more patients that can be taken out of the ED at pace, and it's really good to see that improvement. And I know from talking to the trust, it's a morale booster for the ED department in particular, who have felt the pressure of all of this. We've also been asked to lead, from an ICB point of view, a review and options appraisal of the extra capacity implemented in the summer and the front door model of care at the Worcester Royal Acute site. So we're actively working on that at the moment. It's due to be complete next week. That is because we didn't see the impact of the additional capacity that was put in place straight away. There's more additional capacity coming on in November, which is really good in the new as part of the new ED. The new ED won't be in place until early next year, but there is a floor that will help us our same day emergency care. So that will be taken into this option appraisal as well of how we use us. And we did do a clinical and urgent care leads walkthrough last week to support this options appraisal. We have clinical leads experts come on to support that. So still a precarious position, but much better than it has been for quite a long time. Lots of assurance on actions being delivered, getting us ready for winter. Although I would suggest the last few summers in Worcestershire have probably been more challenging than the winters, but we have got extra resource in place to help us, to support us with winter, and I'll describe that in the next paper. Happy to take any questions, Christian.
Thank you, Mary. So any questions or comments from colleagues? Vicky?
I think just to the system-wide risk assessment, Mary, that you outlined, are there specific timescales for that? I know you said it would come back for ICB sign-off, but also the question about the wider partners in terms of YMAS in that risk assessment, as well as the regulator, because obviously the regulator focus on each organisation is clear, but from a system point of view, will they be involved in that risk assessment?
Thanks, Vicky. Yeah, so they want to see the risk assessment, definitely. They want to see the risk assessment. WMAS are involved in that process as well. because of mainly because of the category 2 risk that they hold, they believe they hold, and the front door risk they hold. It is a fully system, so each partner is doing their part of a risk assessment, and we've got our quality lead for urgent care pulling that all together into a nice ICS ICB framework. We need to complete that by the end of this month, so that's the timescale people are working.
Thank you, Mary.
Thanks, Vicky. David Mahaffey? Oh, sorry, Sarah.
Yeah, Krishna, apologies. Just a couple of potentially sort of softer questions, but with regard to the data that we can capture, and it was raised before about health inequalities, are we capturing the information about who it is that are calling ambulances, who's waiting? So we're looking at that kind of access, experience and outcomes of a group of people, and are we seeing any trends there? I appreciate we don't need the answers to that now, but is that piece of work being done? And my second point was there some what looked like positive things being put in place? I'm just conscious that there's not that much mention of wider partners, so a true system approach, primary care, community and voluntary sector, fire service, other broader people who may have risk because of the ambulance delays in their services, but also may provide some innovative solutions that go beyond the walls of the hospitals.
Okay, thank you. So yeah, the work on inequalities, I mean, we have looked at where with WMAS and with 111 where all of the work is coming from. Interestingly, it is in one area of one of our counties. It is in one of our most deprived areas. Not all of them, though. One of our most deprived areas. It is largely the elderly. It's frail elderly that is our driver. Seems to be in our area. I mean, the system-wide plan does include all of our partners. I would say exception with the fire service. We haven't included the fire service. We've not had any recent engagement with the fire service. That is one to think about. Helpful comment. But you know, from a social care voluntary sector point of view, there is the larger Home First Committee plan includes all of those sectors in trying to improve the patient journey. You know, one of the things that analysis at the moment is some of the handoffs, I call them, between all of those agencies. We could do a lot to improve the efficiency and effectiveness of those, which is something that is being recognised at the moment. It really would help place to integrate in a more structured way as well.
Thank you, Sarah, for the question. I mean, I think Sarah rightly referenced outcomes, experience and access, and I wrote those 3 words down because I think it's really important to say that the risk that Mary has outlined in the paper actually, you know, we must improve this performance, and it's within our gift to improve it. I mean, I think we have seen that actually changing processes, using the North Bristol model in this particular instance, and improvements that Mary highlighted that Herefordshire have taken as well. You know, all these things actually can make a difference to improving the flow, and actually. The performance we've had, particularly, I think category 2 was mentioned. You know, there is a real risk to our community in not being able to access ambulances at the time when they need them. So that's where the risk really lies in our community and for our population, because actually, you know, it's clear that the sort of handover delays would have a detrimental effect on outcomes, experience and access. So I think it's really important to say that in that context, it's very, very important that we maintain our focus on this. Mary's highlighted the national focus on this in any case, but you know, I think my message is it's within our gift. We need to control this, and we need to do our very best to improve the performance. And it's great to see some early signs of improvement through the implementation of the North Bristol model, as it's been called, and it's really important that we sustain that. And for me, that's all about, you know, it's a good example of good practice actually being looked at and brought in and implemented quickly, and then you know, hopefully taking effect, and that is something we really need to focus on going forward. So if there's no other questions or comments, Mary, thank you for taking us through that. I think it's helpful for all of us to understand and have ownership of this improvement opportunity. Sarah Raystrick highlighted this is a system issue. Clearly there are opportunities within each trust to improve performance within each acute trust, but certainly there are system things that we can do as well. Hannah.
Thank you, Krishni. Clearly there's a bit of a delay in the emails coming through. So there's another question from Nigel that's just come in. There is much increased risk in general practice with ambulance delays. Patients and doctors have to make pragmatic decisions about self-transport when this is often far from ideal. So I guess it's less of a question and more of a statement, but yeah. I think it's just important to note.
Absolutely. I think it, you know, I think there's been evidence, hasn't there, Mary, of increased walk-ins because people have done that very thing. Am I right?
Yes, we have seen that, and we've had some stories. Well, we've had some incidents raised by primary care about the risk they are taking as well. Collected all that as the evidence.
Yeah. So it's absolutely a sort of significant issue, as we've said. So Nigel's quite right to note that. Thank you very much. Now, moving on then from that and building on that really, because Mary sort of referenced this already, but there is a requirement for us to make sure we're resilient through winter. Although I do wonder whether the concept of winter is somehow a little bit outdated increasingly, because winter sometimes seems to be with us all year round, and certainly this summer has been particularly challenging. But Mary, do you want to highlight some key things that we need to be aware of? And I think there's a requirement for us to be very sighted on this winter resilience plan, isn't there? And the ICB is expected to keep strong oversight of this. So over to you, Mary.
Thank you. Yes, so I will be brief on this one. So as from an ICB point of view, we are in the final stages of developing our winter plan, and our ICS Urgent Care and Community Board, which I think is tomorrow actually, should be seeing the next iteration of this. We want it finalised by the 1st of October. We obviously, this is an overview document from an ICS and ICB point of view, and then the place bases have their own operational winter plans aligned to that. National briefing gives us these 8 core objectives and actions. Now, nearly all of those we had already in train. In fact, all of them we did have in train, and we're just making sure that we're integrating those into our plan. And we do need to take note now of a new NHS assurance framework for winter. It's a very detailed dashboard behind the winter assurance that will be required to give to the regional and national team that we're integrating into our performance framework. So we've integrated, just not to have 2 plans, we've put the ambulance handover improvement plan and the winter plan together just to try and keep communications simple for everybody. And we are about to launch, particularly in Worcestershire, a comms plan around the ambulance improvement handover and the winter plan aiming to get to every clinician operational lead on the front line, so they understand where the improvements are. Demand and capacity planning is really important. It's really challenging. In any system, there's national tools that are recommended to use. We are coming to the finalisation of that demand and capacity planning by the end of this month. In Worcestershire at the moment, it's still showing a small deficit in beds. Herefordshire work is still underway, but through the Urgent Care Board of the ICS, we will get the final version of that and determine what actions we need to take, if any more than we've already planned, to mitigate that risk. We have had some regional, national money for winter schemes. We have taken the decision to focus that on the immediate actions that we can take to stabilise the position, as ever the resource comes in quite late. So we are focusing on addressing any bed gaps that we have in our system, trying to mitigate those, and putting additional capacity into our most challenging at-risk areas. across the ICS for urgent care to help them. Now, some of that is a risk because it's workforce dependent, so we'll be monitoring that very closely, and we may be adjusting the use of some of this plan as the winter goes on. But it's all designed to help to reduce that risk, particularly at Worcestershire acute, although there is some resource going to Herefordshire as well for escalation beds over winter. So the high-level risks of this winter plan are workforce, the ability to attract those additional roles and keep the people in post that we've got now, which is a very challenging position. Market availability, particularly care home responsiveness to the demand for additional nursing beds. We're wanting to procure additional nursing beds. That's becoming more increasingly difficult because of the sustainability of some of the homes, because of the cost of running these businesses and their own workforce challenges as well. And for market availability in the domiciliary sector is equally as challenging as well. And then just making sure that we're, as I said, communicating this plan out widely to everyone in a simple way that integrates improvement rather than causing confusion. So we will monitor this very closely through the ICS Urgent Emergency Board, and will escalate to board issues that we.
Thank you, Mary. Any comments or questions for Mary? Jane?
I'll just make a comment. Thanks, Mary. I guess just one comment is this does feel pretty NHS based, and I know that's not the intention, but it all does seem to talk about NHS, and actually we know the most significant risk to NHS urgent care is more around social care restrictions on capacity, as you've mentioned, and so I think we do need to broaden it out to make sure we really do understand the risks coming up to winter for social care providers. The other thing that I think we need is an articulated escalation plan for us. All of this work doesn't mitigate all of the risk. In what order will we do what? Otherwise we'll be in crisis mode and not necessarily making the right decisions at the right time. I think, and Krishni said it, and absolutely right, the biggest risk we've got to our population is not being able to get an ambulance to them when they need one in a timely way. So this morning, it was a particularly bad day, but this morning there were 44 patients waiting for admission in Hereford's ED. It can't go any further than that. If some of these things don't work, we will have to make some decisions about what we're going to do. And I think we need to articulate and have that escalation plan agreed, because some of those things, are going to be very difficult.
Thank you, Jane. Mary, do you want to comment on those?
Yeah,
do you mind, before you do, I just wanted to pick up a little bit of what Jane said, because I'd written down sort of care home fragility as sort of one of the concerns that keeps being vocalised, and certainly Amanda Pritchard, I think, talked about that at a recent event. So that does what, I don't know whether we've been able to assess the risk of that, which I think is Jane's point as well, is risks on that kind of wider front, so that we understand what, if anything, we can do in response to that. So over to you, Mary.
I'll answer that one first, if that's okay, and then come on to the escalation. So we have, across both places, done a very quick piece of work to understand the vacancy factor in our care homes, which is quite significant. We have plenty of empty beds. What we haven't got is staff and enough resource to use all of those. So we were asked to do this part of a national exercise, so we have got that in place. The responsiveness of these care homes is being tested as we speak, particularly in Worcestershire, because we're trying to procure extra home care home spaces to support what we call Pathway 3. The responsiveness is slow from the individual businesses to the councils, responding with their availability, their ability to take patients, taking what we call trusted assessment, taking without coming and seeing the patient and assessing them and their whole family takes a long time. We need these patients to move quickly. So we are working, particularly with the councils. I know we do it in Hereford and Worcestershire, on a trusted assessment process, how we can get that in place. But I have to say we've tried this for many years and not been able to influence these independent providers to do that. I think the biggest risk that we've got at the moment, though, as I said earlier, is the cost of running these businesses. And I know there's a couple of care homes that have come forward and said we're not sure we can be in the market anymore because of the cost of this, which would be a major risk to flow within our system and systems across the country. So, you know, I will take this back to the council leads again and get further assurance about what they're doing. It's limited what they can do at the moment. They are a bit scratching their heads as to how to handle that one. But we will continue that work and bring it more forward into the ICS Urgent Care Board. I think probably the way to do that. We have representatives there. The escalation plan. So Jane, good comments. We'll enhance our escalation plan further. We have our gold, silver, bronze escalation across the ICS. We'll escalate that. We'll embed the actions here to make sure that if things aren't working, we can make sort of more fleet of foot decisions on how we redirect resources to the most appropriate place. So I'll take that back as an action and make sure we do that. Okay.
Thank you, Mary. Hannah?
Thank you. Question from Nigel Fraser. Despite the guidance and our clinical model of left shift, there does not appear to be enough emphasis on out of hospital intervention in our winter plan.
Okay, thank you. I'm happy to come back on that. So obviously, as I think we said in here, so the resource that we've been able to secure, we were told quite firmly, was to first and foremost reduce the ambulance handover risk, because that was seen to us. We have looked across the system about where we needed to place some of that additional resource. We have invested in more virtual wards. We are investing in virtual wards in both Herefordshire and Worcestershire. We're just signing up. We signed off the plans. I think it was on Friday last week. We are looking at extending MIUs, particularly in the north of Worcestershire, the opening hours, because it helps the Alex Hospital, which has an inadvertent effect on ambulance delays. So we've had to make that decision to bring everything back to reducing the ambulance delays. So, you know, if we have more resource come down nationally, and we're not sure there's definitely going to be, but there is noise, there will be more resource coming down for winter. We'll obviously look broader across the system.
Thank you, Mary. I was going to mention, I was going to ask about virtual wards, because that seemed, you know, one of the key sort of ingredients and enables, but you referenced that. So clearly that's an active part of the plan. I mean, clearly that needs infrastructure to be able to support it, and I just wondered whether, you know, we feel confident that it is something we can enable. So I don't know if, Will, you want to comment on that before I bring Simon in?
I think, yeah, it's a difficult one, especially given the workforce discussions we had earlier in this meeting, which is, I think, probably going to be our key rate limiting step with the ability to put virtual wards on the ground, including the medical workforce. However, both Herefordshire and Worcestershire have put together fairly robust plans to start virtual wards, and also a way to sort of see if they are making the changes and the delivering the outcomes that we want them to do. So we have a plan. I do think that, yeah, you're right, the workforce resource is going to be the big issue, but I think we have a place where we can start and build on constructively over the winter to see whether we can deliver the outcomes we hope they will. Nice.
Thanks, Will. Thank you. And one, maybe one final comment from me, and then I think Simon wanted to come in, but put your hand down.
Raise virtual wards, and you've covered it now. So.
Okay. Just one final comment from me then. I guess it's just a thought around how we help, how we ask help our public and patients to help us. So there's something about just the comms in that. I think you might have mentioned that, Mary, but I'm wondering whether there's a sort of comms and engagement plan that just helps us to communicate with people about how best to access services during what will be quite a difficult period of time.
Thank you. Yeah, Tom might want to come in as the expert on this, but we do have an annual, you know, winter communications plan. Largely, this is driven nationally about, you know, right place, use the right service, etc. But yeah, that is part of our winter planning process every year, so that will be going. We'll use the national material wherever possible.
Great, thank you very much, Mary. If there are no other comments, then I think at this stage, Mary, we're just asked to note the position, I think, aren't we? Because this is going for further review. The plan as it stands will be going for further review to the relevant board. But you'll take forward the action around sort of clarity around escalations, which I think is the point that Jane made. Yeah. Great. Thank you very much. Okay, so we have concluded the performance element now, and we are moving on to ICB financial plan. So Mark, over to you on this.
Thank you, Chair. So I'm just pulling out some of the highlights then within the financial plan. So the position is up to month 5, which now takes us up to the end of August. And just to remind the board, our part of the plan was a £6.6 million surplus, which was part of the overall financial plan for the system. And within that £6.6 million surplus, the ICB had put £31.2 million worth of support into the trusts in order to get the plan back down to a £14.8 million deficit. The plan will be audited, so we've got to have a 3-month audit of the plan for the first 3 months of the predecessor organisation, and then a 9-month audit for the ICB. So we're at month 5, and as you'll see within the report, then we're currently £1.6 million behind plan. So we should be at a 2.3 million surplus. We're actually a £700,000 surplus, and effectively we are off plan at the moment and are flagging that we have what's called £6 million worth of unmitigated risk. So if the trend continues in terms of spend and we can't find mitigations, which is looking very unlikely at this point, potentially we could be £6 million off plan. Now the implications of that would be the ICB surplus would move from 6.6 to 600,000 surplus, but the overall system plan would go out £6 million. Now you'll see within the report then from Appendix 1 the full breakdown of our portfolio. At month 5 we're seeing pressures against mental health section 117 placements, which is 23% up compared to where we were previously. Prescribing is slightly over plan, but we've only seen 3 months worth of data. But the largest area of spend increase we're seeing at the moment is against continuing healthcare. So at the moment, continuing healthcare has a large year-to-date overspend, and if the trend continues, we'll have a large overspend at year end. So it could be £12 million overspent at year end. Now the drivers are mainly price related. So during COVID and post-COVID, we expected prices to start to step back down, and so we've come out of the end of COVID. We're not seeing that. Price levels have continued to stay at a high level and are continuing to increase. There's a mixture of inflationary pressures linked to workforce, utilities, energy. They're all driving higher prices in the market. And as an average, we've gone from around £900 a week in a care home to at the moment running up to between £1,600 and £1,700 a week in those areas. From an ICB perspective, we put a 4% inflationary increase in. That was above what the national allocation was for inflation. We're seeing an average request at the moment of around 11% from the market in terms of the inflation uplifts they're looking for. It's also worth adding we are seeing a number of providers serving notice. As Mary said, it's too expensive now for them to operate in the market. Therefore, they're serving notice on some of the packages, which isn't good for continuity of care and also puts additional costs in them trying to re-procure. It is worth adding, as an NHS body, we did get additional inflationary funding in from NHS England in July, but none of that was specifically targeted to continuing healthcare. We flagged the pressure and the risk to NHS England. We're having a deep dive with them on the 28th of September to go through all the operational side, but also the financial side around continuing healthcare. And not only does it give us a pressure this year, but it'll also give us a bigger pressure going into 23-24, because this side shows no signs of slowing in terms of the spend against this area. We will share that deep dive once we've been through it with the NHS England with board members, so you can specifically see what's in there and some of the drivers. But at the moment, as we sit here today, I'm advising the board there's £6 million worth of unmitigated risk. We can mitigate a big chunk of the pressure, but it's non-recurrent mitigation. The 6 million I currently can't mitigate at this point, and that does put us in a risk position as we head towards year end, but also that we're off plan year to date at this point as well. So I'll stop there, Chair, and take any questions on anything specific in the report.
Thanks, Mark. I think just on the continuing healthcare, I know you said that there's a deep dive with NHS England, which is helpful, because I guess through that there might be some action we can take, further support we might get, etc. But is this a problem that other systems are also reporting, or is this unique to us? Because if we're all in the same position, that helps, but obviously if it's a unique position to us, then that perhaps doesn't. What's your thought on that?
Thank you, and that's one of the things we've actually looked at, and I've been talking to colleagues, and I know Simon's spoken to his colleagues as well. Particularly the Shire areas are seeing more pressure around continuing healthcare than compared to probably inner city areas. So Shire areas are reporting a problem. Again, they're finding ways to try and mitigate as much as possible this year, but they're flagging risk. They're all saying they've got a bigger problem in 23-24. I think we're slightly ahead of the curve in some of this because of the work we've done to identify the pressure, the risk, and we always know Herefordshire and Worcestershire is a place where people do come and want to retire, which is great, but at the same time, then that does put more financial pressure from a demographic perspective on this area. So other areas are reporting it, probably not to the same level we're seeing at the moment. There are things we do need to look at ourselves. So we're going to start a conversation with both our local authority partners around a market management framework and how we can look at trying to agree prices for specific areas, so that again the market knows specifically the framework we want to work in. That will help going forward, but at the moment we see ourselves in a position where supply, demand and what the market is looking for price wise is causing this significant financial challenge.
Thank you, Mark. I think that's all very clear. Unless anyone's got any further questions on that, I think, Mark, you're just asking us to note the position at this stage, and clearly there are some actions in hand, as you said, to look at further mitigations or support that might be given to us as a result. So I'll close the item there. Thank you very much. Unfortunately, some of our technical challenges, I think with people, the way people have had to join does mean that there's the odd kind of announcement as people are coming in and out. So apologies for that. We move on to item 15, which is the assurance item. We have got a collective report which covers all of the committee chairs and on committees. Hannah, did you want to say anything at this stage, or should we just hand over to the chairs if they have anything they particularly want to highlight?
Yeah, thank you, Krishni. Just to introduce the item, really. So this will be a regular report to the board. Like Krishni said, this will kind of discharge the statutory responsibility of all the committees that have got duties delegated to them by the board. So we've had, obviously, we are still at a very initial stages of the ICB establishment and operation. So all committees have met once, but once only, which means we don't have any approved minutes to share with the board. But other than that, yes, I'm just happy to hand over to the chairs in case they want to add anything specifically. Thank you.
Thank you. So obviously Graham is not with us, so I don't know, Aman, if you wanted to mention, I know one of the issues that we just wanted to bring to the attention of the board was the challenges around the external auditor.
Yeah, Yeah, just a brief update on that really. I know Mark's having conversations with NHS England, so it's been escalated to the highest level and we're trying to resolve that situation. But at the moment those conversations are happening. They're aware of the risk, they're aware of the challenge, and we'll update the board accordingly once once Mark's finished having those conversations.
Great, thank you, Arman. That's really helpful. Is there anything else you wanted to add in Graham's absence?
Yeah, just in terms of the internal audit plan, we're looking at taking a more system-wide approach. So that will probably involve engagement with other audit chairs and exec members to ask for ideas around areas of focus they might want included on the internal audit plan. So that's something that we'll be looking to do going forward. That's it from me, really.
Thank you, Arman. That's really helpful. Okay, so Martin, I should have acknowledged Martin was filling in, covering QRD for us whilst we were in the process of recruiting Vicky. So welcome to this meeting, Martin. I should have said that at the beginning. But Martin, anything you wanted to highlight in particular?
Thank you, Christian. Briefly, yes, as you say, I've been the interim chair of the Quality Resources and Delivery Committee. So I would also like to welcome Vicky, who is going to take over this role. I think a significant challenge will be how we develop and establish how the QRD operates across the whole of the system, engaging with partner organisations in managing the key quality and resource and delivery challenges, and also how it'll play a major role in receiving high-level risks and seeking assurance that they're being dealt with appropriately across the whole system. So it's going to be a real challenge doing that. And we had some discussion at the first meeting, which was helpful, and there has been a suggestion that a workshop should be held so we can explore that in more detail. I mean, going forward, I'm sure the committee will continue to have a strong focus on all the issues we've been discussing today, challenges around specialties and performance standards. Thank you.
Thanks, Martin. I think it's a really important point, because this is about how we also, particularly on this agenda, how we make sure it's additive, it's adding value rather than duplicating what quality committees are doing around different organisations. So it is a really important area of focus, and I think that sounds like a welcome step to take that discussion forward. Sarah next. I mean, please don't feel you have to comment, but if you do want to highlight anything, Sarah, Simon or David. So I'll just, Sarah, anything particularly? No, okay. Simon?
Nothing to add, thank you.
And David?
Also nothing to add, thank you.
Great, thank you very much. So we'll note those reports, and obviously these will be a key part of our assurance going forward. And our opportunity to delegate to these committees if we feel there are areas that we would like the committee to explore further on behalf of the board. So thank you very much, Hannah and our non-executive chairs and Simon for the content of those. Now, final item then, Hannah, on the ICB board assurance framework and risk update. Over to you.
Thank you. So this paper is a bit of a holding paper, really, a bit of a holding position for now. So clearly we will have a board assurance framework as a board. Obviously, what we really wanted to do is make sure that it's linked to our ICB, to the priorities that we have agreed, which we have only just agreed today. So I didn't really want to go in and set up a board assurance framework sort of that hangs off something that we have not yet agreed. So just wanted to assure that the work is in progress. We are doing a thorough review of all our risks and scoping of any new risks. So this is both strategic and corporate risks. And we will be taking a paper to audit committee next month, which will hopefully endorse our approach and a comprehensive list of all our risks, with a view of bringing the full board assurance framework to the board next month. So really it's just to assure that the work is in progress and you will have sight of the board assurance framework within the next few weeks.
Thanks, Hannah. Any questions or comments? The only thing I wanted to check, Hannah, is in terms of the risks that existed previously under the banner of the CCG, how are we making sure that we don't lose sight of anything that we thought was a risk as of 30th of June 2022, but somehow isn't a risk on the 1st of July. So I just wondered whether, you know, how we're transitioning that piece of work, really.
Thank you. So absolutely. So that's really our starting position for our risk review. So we're taking the CCG risk register as our starting position. We're meeting with all the exec leads. So that's myself and Tony in the governance team, and we're carrying this piece of work out over the past couple of weeks and the next couple of weeks, and really just reviewing any existing and past risks, making sure they still fit. I mean, some of them will not change. Most of them will change in the view of going into an ICB. So some are kind of being tweaked and moderated, and there will be some new risks which we didn't have previously as a CCG, but we will have as an ICB. So those risks that can be closed from the CCG risk register will be closed, some will be amended and new ones will be opened, and that will be all submitted to audit committee next month.
That would be good. I think if audit has a sort of a full overview of what's not regarded as a risk in the new setting, I think that would be helpful, and then that can be additional assurance. Thank you. So unless there are any other questions, I think we have actually concluded our business, which is quite a surprise as we started a little bit late. So I'm surprised. Simon wants to come in, but can I just say apologies again for all the technical challenges. Obviously that has meant that some colleagues haven't quite been able to participate, I think, to the extent that would have been ideal, but we will we live and learn, and we will, I'm sure, look at what we need to do differently to make sure that's right. But hopefully people have felt through the processes we established that there were opportunities to contribute. So and also apologies to members of the public who were kept waiting at the start. Simon.
I was only going to say that, look, apologies for the technical difficulties. We'll make sure we understand why those have occurred, and we'll put in place arrangements next time so that they don't happen again. It's unacceptable. We want the meeting to be engaging, don't we? And well done to people for their engagement despite the barriers that have existed. But we'll resolve that for next time, Krishni. So just again repeating what you said. So at least we're on the same page. We're
on the same page. Excellent. Thank you very much, everybody, and thank you for taking part in the meeting. And I'll close the meeting. Thank you.